Buongiorno a tutti, sono la dottoressa Virginia Moscone e presenterò uno studio riguardo la definizione di nuovi biomarkers prognostici per l'osteonecrosi da un punto di vista multidisciplinare. Come ben sappiamo, attualmente non è possibile prevedere se un paziente svilupperà o meno osteonecrosi dopo aver assunto farmaci antiriassorbitivi, poiché non ne esiste un valore soglia a livello plasmatico od osseo oltre il quale presupporlo con sicurezza. Oltre a ciò, manca ancora in letteratura un'evidenza scientifica riguardo al ruolo del microbioma salivare nello sviluppo di osteonecrosi farmacoindotta. Questo studio, dunque, si è posto l'obiettivo di valutare nuovi possibili biomarkers prognostici attraverso un'analisi di aspetti microbiologici, farmacorelati e genetici, che potrebbero essere implicati nella biodisponibilità di questi farmaci, così da prevedere lo sviluppo di osteonecrosi. Abbiamo quindi arruolato 16 pazienti affetti da patologie oncologiche o da disordini osteometabolici che avessero assunto denosumab o zoledronato. Successivamente i pazienti sono stati suddivisi in due gruppi, un gruppo A di 8 pazienti che hanno sviluppato osteonecrosi e un gruppo B di 8 pazienti che non l'hanno sviluppata. In seguito abbiamo analizzato per ciascun gruppo la composizione del microbioma salivare, la concentrazione di farmaci antiriassorbitivi a livello plasmatico ed osseo e la presenza di polimorfismi in quei geni legati al metabolismo o all'eliminazione di questi farmaci. Ovviamente abbiamo anche valutato fattori di rischio quali fumo e alcol. Dai risultati è emerso che il gruppo A presentasse un maggior consumo di alcol e una età media più bassa. Inoltre, la maggior parte dei pazienti che ha sviluppato osteonecrosi era di genere femminile. Per quanto riguarda l'analisi del microbioma, il gruppo A presentava un aumento di neisserie acee. Anche il dosaggio dei farmaci sembrerebbe avere un ruolo, in quanto il gruppo di pazienti che ha sviluppato osteonecrosi aveva ricevuto soprattutto farmaci ad alto dosaggio, sia per via endovenosa che sottocutanea. Infine, i risultati hanno suggerito il ruolo di un polimorfismo genetico particolare, anche se con un minore impatto. Questo studio ha valutato molti aspetti potenzialmente coinvolti nello sviluppo di osteonecrosi farmacoindotta. Il dosaggio dei farmaci antiriassorbitivi a livello osseo e plasmatico è oggetto di uno studio attualmente in corso e per il momento mancavano dati sufficienti per ottenere risultati statisticamente significativi. Ovviamente, senz'altro sarà necessario condurre ulteriori studi per confermare i risultati preliminari emersi, includendo un campione più ampio di pazienti. Grazie mille dell'attenzione.
Hello everyone, my name is Lorenzo Pavone and this is our contribution to ONJ Update 2024. Medication-related osteonecrosis of the jaw is a severe side effect characterized by a non-healing necrotic bone tissue of mandible or maxilla in patients taking anti-resorptive drugs, such as denosumab and zoledronic acid. According to current literature, the pathogenesis of ONJ appears to be multifaceted, and evidence supporting a central role of immune dysfunction has been growing over time. To evaluate whether different anti-resorptive drugs could induce ONJ through different mechanisms of action, we investigated circulating immune subsets and pro-inflammatory cytokine release. We believe that adding insight in the pathogenesis of ONJ is fundamental to improve the clinical management of patients undergoing treatment with such medications. In a one-year study, we selected 8 bone metastatic breast cancer patients treated with zoledronic acid or denosumab for the prevention of skeletal-related events who developed ONJ and were subsequently scheduled to undergo sequestrectomy along with the use of PRGF in order to improve wound healing and prevent surgery failure. On the day of surgery, we obtained a peripheral blood sample from which peripheral blood mononuclear cells, also known as PBMCs, were isolated and used for an immunophenotypic analysis of different immune cell subsets by flow cytometry. Through a multiplex analysis conducted on sera, we also assessed the presence of differences between the levels of different pro-inflammatory cytokines among the two ONJ groups. In the zoledronic acid group, we observed a significantly higher level of CD4 and CD8 T cells and a decreased level of CD4, CD69 T cells compared to the denosumab group. The level of gamma delta T cells was lower in the zoledronic acid group compared to the denosumab group. Significant differences also emerged by the analysis of cytokines and chemokines in sera, showing a higher level of interleukin-8, interleukin-17, MIP-1-beta and TNF-alpha in the zoledronic acid group compared to the denosumab group. The two anti-resorptive drugs considered revealed a different capability to modulate immune subsets and pro-inflammatory cytokine release. This could explain the clinical differences between zoledronic acid and denosumab-induced ONJ. We believe that these preliminary data deserve further investigation since they could help identifying the different regulation of immune cell subsets exerted by zoledronic acid and denosumab, thus opening new therapeutic perspectives. Thank you for your attention.
Hello, I'm Ilaria Roato, and this is our contribution for ONJ Update 2024. As you can know, medication-related osteonephrosis of the jaw is characterized by non-healing necrotic bone tissue or mandible or maxilla, and anti-resorptive drugs such as zoledronate and denosumab target osteoclasts, inhibiting their formation and activity, thus blocking bone resorption without a contemporary stimulation of osteoblast activity. For this reason, there is an uncoupling of osteoclast and osteoblast activity, hindering the healing of the affected area that are characterized by bone resorption and necrotic bone. We aim to understand whether the local bone resorption could be linked to a more systemic dysregulation of osteoclast compartment, and to test the biocompatibility of a 3D printed scaffold potentially useful for a regenerative approach in the bone necrotic area. We analyzed osteoclast precursors in peripheral blood of patients with bone metastasis before starting anti-resorptive drugs, and after 6 months of treatment, observing a decrease in osteoclast precursors circulating. In patients with MRNJ, we observed again a low level of circulating osteoclast precursors, suggesting that the anti-resorptive treatment is effective in the control of the osteoclast compartment. We also test the capability of osteoclast precursors to form in vitro osteoclasts without adding the osteoclastogenic factors such as MCSF and RANKL, and we observed that this osteoclastogenesis was significantly reduced in PBNC from bone metastatic patients treated with anti-resorptive drugs, yet after 6 months of treatment, but the osteoclastogenesis was also reduced in patients with neodiagnosis of MRNJ. And here you can see the trap staining typical of large and multinucleated cells, which are osteoclasts. At last, we decided to test a 3D bioprinted scaffold constituted of resorbable materials such as polycaprolectone and alumina to sustain the mesenchymal stem cell growth and osteoblast differentiations. And this material was biocompatible, and this cell bioprinting customized scaffold could be useful for a regenerative approach to replace the necrotic area. Of course, these are preliminary data, and we need to test these scaffolds probably in vivo models. Thank you for your attention.